acid on something, what happens to it? It's kill it, right? So normal urine is slightly acidic, and that helps ward off urinary tract infections. When the urine becomes more alkaline, that's when bacteria can grow. Okay, so we like having a little bit acidic urine. That's important. And so normal urine will have these characteristics. So let's start on page 284 at the top. We've got characteristics, we've got normal, abnormal, and nursing considerations. So it says under characteristics, usually and it says an amount in 24 hours for an adult. Normally, your book here says between 1,200 and 1,500 milliliters. I know, I just said a minute ago that we usually put out about 2 liters, which is around 2,000 milliliters. These are just ranges. That's not gonna mess you up on a test, because I'm not gonna ask you how much urine does an adult put out. But just know we have a range, right? Where we're gonna be putting out somewhere between 1,200, 1,500, maybe 2,000 milliliters a day, depending on the size of the patient, depending on how much that patient drank during the day, whether they ate things like watermelon during the day. So it's all just a guesstimate. So don't get hung up on those numbers there for the amount. But do know that that's roughly the amount that someone puts out in a day, so that if I say they put out 6,000 milliliters of urine, or 60, you'll know those two ends are abnormal. So that's just applying the general knowledge that you know where people put out the amount of urine. Abnormal would be less than 1,200. And then nursing considerations, it says, normal urinary output is approximately equal to fluid intake. Output of less than 30 milliliters per hour may indicate decreased blood flow to the kidneys and should be reported immediately. So that's definitely something to highlight and remember. So when we go down the list here, we've got color. The normal color for urine should be a light straw to an amber yellow. That's color. Abnormal colors would be a very dark amber, dark orange, red, or dark brown. If you see urine that looks like that, that is abnormal. And under nursing considerations, it says dark yellow to brownish urine is concentrated and may indicate dehydration, fever, or the first urination in the morning. So why are they talking about the first urination in the morning? Right, so that urine sat in your bladder for 8 hours during the night and just sat there and sat there and sat there and got more and more concentrated. That's why sometimes your first morning urine looks a lot darker than your other. And at the bottom of the nursing considerations for the section on color, it says red blood cells in the urine, which is called hematuria, blood in the urine, hematuria, may be evident as pink urine, bright red, or rusty brown urine. It has that blood tint to it. And then it says menstrual bleeding can also color urine, but should not be confused with hematuria. Okay, so if you're dealing with a woman of age that she may be menstruating and you see blood, you need to ask, are you on your period? If she is not, then we potentially have blood in the urine here. Okay, the next section says appearance or clarity. For normal urine, the urine should be transparent, should be clear. Now it might be clear as water, like no color, but it's clear, or it might be yellow if you've taken vitamins, but it would be clear. You could see through it. There's no sediment in it, there's no pus in it, there's no anything to indicate that it's abnormal. It is clear. That's what we should see. Abnormal urine would be cloudy urine, or it have mucus plugs or sediment in it. And under considerations, it says hazy or cloudy urine indicates bacteria, pus, red blood cells, white blood cells, phosphates, prostatic fluid, or any of those things. Milky urine is indicative of pyuria. Yellow foam results from bilirubin or bile, or severe cirrhosis of the liver that you would see in a patient who has liver damage. The next section is odor. So normal urine only has a very faint, we call it aromatic odor. It smells like urine. Abnormal urine is offensive. It is like the ammonia can burn your eyes. It's like, you know somebody's been in there and that urine is old. If it's smelling like that, they're sick or it's old urine. The odor of ammonia increases with time the urine is outside of the body. UTIs cause a foul or unpleasant odor, depending on the causative organism. Sweet or fruity odors occur in starvation and diabetic ketoacidosis, which is very high glucose. You may have heard that, and I know you haven't had diabetes yet, but diabetics' urine often smells very sweet or fruity. That's because of all the glucose in the urine. Sterility is the next section. Normal urine has no microorganisms in it. Abnormal urine will have microorganisms. Urine in the bladder is sterile. Urine specimens, however, may be contaminated from bacteria from the perineum during collection. So you may have a urinalysis that shows a few white blood cells or bacteria, not white blood cells, bacteria, because the perineum might not be clean when the urine comes out. That's why when you get a urine specimen, you should have the patient clean their bottom before they give you the specimen, okay? Under pH, you see normal pH is about 4.5 to 8. I think I said 4.5 to 5, correct that. 4.5 to 8. Under considerations, freshly voided urine is somewhat acidic because it should be acidic within the bladder unless it's an infected urine sample. Alkaline urine may indicate a state of alkalosis, a UTI, bacteremia. The more acidic urine, it says down there, more acidic urine is found in starvation, a diet high in protein, or cranberries. So where are we with the whole cranberry idea? Why do we tell people to drink cranberry juice? It makes it more acidic, more intensely acidic. And that's good because if urine is acidic, is it likely to have infection in it? Right, so drinking cranberry juice and eating cranberries is a way to help prevent UTIs in people who are prone to UTIs. It's not a natural remedy. It doesn't cure a urinary tract infection. It just makes the urine more acidic to help prevent opportunities for infection in people who are prone. Now let's skip down until you see RBCs, red blood cells. So in normal urine there are no red blood cells. In abnormal urine you might see red blood cells. Blood in the urine indicates kidney trauma, kidney disease, renal stones, aspirin intake, blah, blah, blah. Okay, you don't want to see blood in the urine, that's abnormal. White blood cells, you should see very few in normal urine, but will be more heavy in infected urine. High white blood cells indicate UTI. So, there you go. Some things to remember in case you see anything about a urinalysis. Okay, so questions? tell you if you had an infection in your urine. White blood cells, exactly. What other assessment data or cues would alert you to the possibility of an infection? Okay, so you just talked about infection last week, right? So burning on urination, fever, odor of the urine may be very strong. The color of the urine may be cloudy, may have some blood in it, may have sediment in it. Pain in your lower back, pain upon urination in the urethra, that burning.
Confusion.
Right, if it gets really, really bad, it becomes systemic, and then you begin to have confusion, and then go into sepsis after that. So, right, if they have a catheter, you would look at the tubing to see if you see sediment in the urine coming down the tubing, or blood, or pus, or if the urine is of abnormal color. Right, so cues, those are all cues. So, lucky you've already had this information. If you saw a question that says you have a patient with a Foley catheter, the urine in the catheter looks milky, white, thick, small amount, you know, that sets up a scenario where you automatically think this is an infection. And so you would think about the care that you would provide for that patient. Good. Oh, I got my questions back. Okay. That's not a smart decision, right? As soon as you get a urine sample, it needs to go downstairs to the lab. It doesn't need to sit out on the counter, because if it sits out on the counter, what's gonna start happening to the urine? Bacteria can start growing in it, right? Bacteria love warm, wet places. So any bacteria that's in that urine is just gonna proliferate if you let it sit out on the counter. So don't do that. As soon as you get your urine sample, take it down to the lab. Okay, so we have exemplars of urinary retention and urinary incontinence. Let's see, chart on page 279. Got that on here. Let's look on page 279. Those already have words that you already know. Except on the chart on page 279, it's got the definition for urinary retention as a distended bladder, pain in the suprapubic region, restlessness, and some things that could cause it would be recent anesthesia, recent perineal surgery, perineal swelling like you might have after you deliver a giant baby, right? Lack of privacy can cause you to have retention. Lack of, has anyone ever tried to use a bedpan? If you've been in a position where you had to stay in bed in a hospital and you had to go to the bathroom and the nurse brought you a bedpan, it just isn't natural to use the bathroom when you're laying down. It's hard to do. Men, on the other hand, what do they have to do? They have to get out of bed. They have to stand up outside of bed. You can have a 100-year-old little man that can barely stand, but he is going to stand to go to the bathroom and use that urinal. They have to be in the right position. Urinary retention is discussed there. Urinary incontinence, it says bladder inflammation or associated diseases, difficulty in independent toileting, leakage when coughing, laughing, or sneezing, or if you have some cognitive impairment like Alzheimer's or dementia or stroke, you can have incontinence. So urinary retention is the accumulation of urine due to the inability of the bladder to empty for whatever reason, A, B, C, D, E. Urinary incontinence is involuntary leakage of urine, might be a little, might be a lot. It's never normal to have leakage of urine. Okay, so prevention is the key for urinary incontinence. We've got to maintain a healthy weight, so that might be a teachable moment with your patient. If they're having urinary incontinence and they are obese, it might be that we can talk with them about ways to lose weight effectively. LPNs, you would reinforce that teaching as the RN begins. A diet high in fiber to prevent constipation helps with urinary incontinence, because if you have to strain to have a bowel movement because you're frequently constipated, you're going to, over time, weaken your pelvic floor muscles, and that's gonna leave you in a position where you might have urinary incontinence. So a diet high in fiber helps prevent constipation, and it helps for this situation too. Avoid urinary stimulants like caffeine and alcohol. You know, if you drink alcohol, you have to go to the bathroom. If you drink a lot of caffeine, it makes you have to go to the bathroom, have a bowel movement, and urinate. It stimulates all of them. And on the notes pages down here, I've got discourage drinking of coffee, tea, which have caffeine. Now you can drink decaffeinated coffee and decaffeinated tea. Brown cola and alcohol, because all of those increase urination and urinary frequency. So if you're struggling with urinary incontinence already, those would be things to avoid. Adequate fluid intake, just like you learned, 6 to 8 ounces of glasses a day. Go when you need to go, don't hold it. Keep clean to prevent UTIs and maintain good general health. So on my next pages down here, I've also got have fluids such as cranberry juice available. Cranberry juice and vitamin C help acidify the urine to decrease bacterial infections in the bladder. Okay, so why is it important to go when you feel the urge to urinate? Why not hold it a little longer? Right, you don't want to weaken that detrusor muscle, right? Why is drinking so much water good for bladder health? Okay, good. Not only does it keep you hydrated for all the good health benefits that has, but the passing of urine through the urethra, the turbulence that produces, actually washes out the urethra and can wash out bacteria that is collecting there. So a good stream is helpful for washing out the urethra and preventing that bacteria from falling up into the bladder. So the more water you drink, the more you will put out, the stronger your flow will be. So it's good to drink that water and have good bladder health and produce good amounts of urine. So Kegel exercises is considered a non-pharmacologic therapy for urinary incontinence. That means it's not a medicine, non-pharmacologic, no medicine. It's just an exercise, and it's called, it's a behavioral technique that we do when we're doing bladder training exercises, or some people call it bladder retraining exercises. All right, other things that can help, other non-pharmacological things that can help when people have urinary incontinence would be scheduled toileting. So every 2 to 4 hours, take them to the toilet. Every hour that we round, we need to ask them if while we're there in the room with them, can I help you go to the bathroom? But every 2 to 4 hours, we definitely should be physically taking them to the bathroom. That's called scheduled toileting. Habit toileting is toileting like natural habits dictate. If you feel the urge, okay, that's good. We're gonna get up right now and go to the bathroom. When are some common times people go to the bathroom to urinate?
In the morning.
Right, as soon as they get up first thing in the morning, usually after they eat, because they have something to eat and something to drink, and now they have to go to the bathroom.
As soon as you get home,
Or as soon as they get home, put the key in the door. After a long day, at night before you go to bed, or before you take a shower, those are normal times that people go. So when you're teaching your client, or you're reinforcing teaching with your client, Those are things you would include in the care plan and in the teaching. Habitual urination times. Remind them of these things and write it down so they can go, oh, okay, I need to try and go to the bathroom. I've just gotten up. Or I'm going to bed, I need to go to the bathroom before I go to bed. Help them to remember that. There's a thing called double voids that's also very helpful. So this means when you go to the bathroom, when you finish, just stand there or sit there if you're a woman for another couple minutes, and likely you will need to go again in another minute or so and finish emptying your bladder. Why is it important to do this if you have time, you should try and do this, double voids. Right. So this is especially important for teaching someone who's recovering from a urinary tract infection. Double voids. Sit there, get your urine out, stay there for another minute or two. You will probably feel the urge to void again and completely empty that bladder. We don't want any residual urine in the bladder because it's going to sit in there and potentially become infected. So double voiding is a very good non-pharmacological intervention to prevent UTIs. And it's really good for people who have urinary incontinence, because if you don't double void, that residual urine is going to sit in there, and then the next time the person sneezes, there it's going to go. If they had double voided, the bladder would be empty. And then we have incontinence devices like pads, pessaries, catheters. Do y'all know what a pessary is?
No.
Female pessaries. So, long time ago, and this is just an example, a woman may have had 13 babies. Her pelvic floor muscles are just gone, right? Everything's falling out. They would take a pessary, and sometimes it's a homemade pessary, sometimes it was even a potato. And they would stick it up in there to hold everything up in there, because if not, they are having everything's falling out. Like the bladder is trying to fall out. Every time they go to the bathroom and press down, the bladder comes out. It's terrible. Now they have bladder tucks and surgeries to go in there and tuck everything back up. But a long time ago, they didn't have that. And so when we use pessaries, homemade or not, put up in there. We still see pessaries today, not very often, but they are still a thing. But that is an incontinence device that you may come across. You will not see a test question about potatoes, I promise. I'm not going there. But I do want you to know about it. So this is how to do Kegel exercises. You need to learn this slide. You just need to know how, you just need to learn it. I'm not going to go through it. Put a star on it. Special populations in urinary incontinence. We've talked about children. We've talked about how daytime continence in children occurs for urine, occurs before bowel continence. Daytime continence occurs before nighttime continence. If you've raised children, you know that during the day they can potty pretty well, but sometimes parents will still put a diaper on them at night while they're still little and still learning, because that nighttime continence comes a little later than daytime continence. Teach good bladder health starting at a young age for girls, like from front to back. And functional incontinence for the adult, of course, is not their fault. It just is not. So on pages 288 to 290, you need to turn there and put stars on this section. Starting on page 288, there's a section that's called Lifetime Considerations. It spans the next few pages over to page 290. It's where we're talking about urinary elimination in newborns, toddlers and preschoolers, school-age children, pregnancy, and urinary elimination in the older adult. You need to put stars on those pages and read that section for sure. Not that you don't need to read the other things in this book, but,
Could you go through that list one more time?
on page 288, the whole section called lifespan considerations. It goes through, and it's in blue font, urinary elimination of newborns, urinary elimination of toddlers and preschoolers, school-age children, pregnant women, and older adults. It goes through page 290.
Thank you.
And on page 288, there's a nice table 5-4, that kind of summarizes that as well. We've got that down. We talked about this. I'm not gonna go over that again. Urinary retention means cannot empty the bladder completely. Most common in men with BPH, benign prostatic hypertrophy, that means a swollen prostate gland or an enlarged prostate gland. There are lots of great commercials now out that talk about medications and things that we can do for guys that have swollen prostate glands. For them, they may need surgery. It's called a transurethral resection of the prostate, or TURP, T-U-R-P. They may need a surgery to kind of whittle down that prostate so that you can get in there and open up the passageway for urine to come out. It can also happen in patients with bladder cancer or renal stones because of blockages to the ureters or possibly to the urethra. Can also happen in people with spinal cord injuries because they don't get those signals to the brain that say, I need to empty my bladder, so they end up retaining urine or urinary retention. So these people with neurologic disconnections, whether it's a brain injury or a spinal cord injury or a stroke that's damaged the brain, any of those things, these people may need to self-cath every 4 hours to prevent urinary retention. Okay, so we talked about nurses, making sure you can take time to go to the bathroom so that you don't hold that urine and end up developing involuntary urinary retention. Now, you don't need to do that. Take care of yourself, go to the bathroom. So it says, what is the worst thing that could happen? All kinds of things could happen. Look at the bladder. These are literal distended bladders that you can see on assessment. That is not a hernia, that is a full bladder. A very, very full bladder. I want to, on page 321, turn there. 321, there is a safety alert that I want you to see. For those of you who know me, you know I love safety alerts, right? Some patients experience a vasovagal response. That means they become faint and can pass out. Become pale and sweaty and hypotensive if the bladder is rapidly drained. So if you put a Foley catheter in this patient and drain that bladder, they can develop a vasovagal response or a syncopal response. Syncope means fainting. And they can pass out. They become sweaty and pale and pass out if you drain that whole thing rapidly in one go. So it says draining the urine in 500 milliliter increments and then clamping the catheter for 5 to 10 minutes between increments may prevent that response. So if you put a catheter in them and drain out 500, clamp the catheter. Wait 5 to 10 minutes, drain out another 500 and clamp the catheter. to keep them from passing out. Hematuria, the presence of blood in the urine, may also occur with rapid bladder decompression. Promptly notify the physician if hematuria develops. Okay? So, just food for thought. When you learn to put in a Foley catheter, it's not like they're on autopilot. It's not like you put it in and let it go, because they can actually pass out if they drain too quickly. So if you have a patient that you feel like is retaining urine, one of the things that we can do is a bladder scan. Now, we don't have a bladder scanner in the lab, but it works just like an ultrasound for those of you who have had ultrasounds for your babies. It's just a wand, and you have jelly or the gel we put on the abdomen, and we turn the wand on, and it comes onto a screen on the machine and tells you how much urine is in the bladder. And you need to call the doctor, because there's a protocol about what to do. The doctor may say, if they have X amount of milliliters of urine in the bladder and they are unable to void, then put in an indwelling catheter. Or the protocol might be to do an in and out catheter, which is in, let the urine drain, take the catheter out. But you would need a doctor's order about what to do with that amount of urine. And this is for people who are retaining urine. Of course, if they can get up and go to the bathroom, that's great. We don't need to scan them. If they can get up and go to the bathroom, that's fine. But if they are not able to get that urine out, then let's scan it. Let's see how much urine is in there. It's non-invasive. It doesn't hurt. It's not going to hurt the patient. I don't even think you need an order to do a bladder scan, because it's non-invasive. Then you have that data to talk to the physician about when you call them. So now let's talk about catheters really quick. And like I said, you're gonna learn about catheters in the lab. Foley catheter, Foley is the name of the man who invented the catheter. So on your NCLEX, you probably will not see a question that talks about a Foley catheter, because that's a name brand, and the NCLEX is kind of nixed everything name brand. Just like Kleenex is a name brand, you won't see a question that says that you're gonna give the person a Kleenex. It'll say that you're gonna give them a tissue. So for catheters, they'll just call it a catheter. They may call it an indwelling catheter, which is one that you put in and leave in, which is a Foley catheter. Or it might be an in and out catheter that you put in and take right back out again after the bladder is drained. So on your tests, we're trying to be as much like the NCLEX as we can. So you may just see indwelling catheter, and that means it's a Foley catheter that's indwelling, it's there, it's not coming out, it stays in there for the length of time that the patient has it. And so when we put a Foley catheter in someone, or an indwelling, it has a balloon on the end of it, so that when we get it up into the bladder, we'll blow up a balloon, and that seals the urethra, so urine doesn't come out except through the catheter. And the balloon only gets to be about that big. It's, gentle on the bladder, and sits in there, and then can drain. We can attach the indwelling catheter to a leg bag, or we can attach it to a bag that we hang on the side of the head. But either way, an indwelling catheter stays in the patient. All right, this is what an indwelling catheter looks like. You have a device here to hook up to a drainage tube. This is the little port that we put we don't put air in the balloon, we actually put saline in the balloon to blow it up. Not air, but saline. And then down here is where the balloon is located, and when it's blown up, it looks like that right there. Then we have straight catheters, which we consider an in and out catheter like this. It's just a plain tube about that long. And that orange tip on the end of it is where you can attach another tube if you need to, or maybe a syringe. But you put the slick in the patient with lubricant, and urine just comes right out of it, drains into a collection device, and then you take that catheter out and throw it away. It's a one-time use in the hospital, in and out catheter. This type of catheter in blue here is a type that the people would use at home if they were paralyzed and had to self-cap. That's the type of catheter that they would use. This over here is called a condom catheter, and it fits over the penis just like a condom, and is secured, and is attached to a leg bag here. Sometimes people who have severe incontinence would elect to use a condom catheter. They can put their pants right over it and go right on. Then we have another catheter type over here called a coude catheter. And if you can see, the tip end of it is kind of bent like a book. And that's a special catheter that we can use, especially if men have swollen prostates, because it's a little stiffer, and we can get it down into the urethra and past that swollen prostate and up into the bladder a little bit easier than a straight catheter, which is a little softer and flimsier. Typically, we need a special order to use a coude catheter because they are stiffer and can be more traumatizing. And so, if it says, we have to have an order to put any catheter in a patient. And typically we use an indwelling if it needs to be indwelling, and then a straight cath if it's just an in and out. But if it's a man with a very swollen prostate, we have to get a special order to use a coude catheter for men. And you see how that's just got the end of it is different than a straight cath. It's rounded and smooth and soft and a little flimsier. So catheters, did you learn about catheters when you learned about UTIs? Okay, that's okay. On the notes pages, I've got sizes for men and women and children. These are estimated sizes. I'm not testing you on it, but I want you to see that, pediatric patients get a small size. We call, the sizes are called like an 8 French or a 14 French. And the French is, again, the last name of somebody who had developed the internal width of a catheter. And an 8 French has a smaller internal diameter than a 14 French, which has a big old diameter. So for an adult patient, we typically use 12 to 14 French because they are larger. And in children, we might use a 5, 6, 7, or 8 French because they're much smaller. So you'll see that when you learn how to put catheters in a lab, you'll use a 12 to 14 French to practice with. And that's just what that means. So on your notes page down here at Scott, make sure to read the section on catheterization on pages 248 to 253 in your skills book. How to care for the catheters on pages 246 to 47. Suprapubic catheters are talked about in your skills book. A suprapubic catheter is one that goes through the stomach into the bladder instead of through the urethra. It's surgically implanted through the stomach, and it drains urine straight from there. How to use a condom catheter or an external urinary device. So those are some reading pages that you need to do from your skills. Page numbers, they're on my notes pages here. Okay? They're all on my notes pages down there. The next page talks about some catheter do's and don'ts, like do not disconnect the tubing from the bag. It's all a sterile system, it's all connected. If you disconnect the tubing from the bag, you break that sterility and put the patient at risk for developing a UTI. So in all cases, as much as we can possibly help it, we keep it in one whole system and don't disconnect those two. Do not let the bag rest on the floor. Like in this picture, that bag is hanging on the floor. How is that a problem for the patient? So that little green spout that you see, that we actually empty the urine out of the bag and measure it, if that green spout is laying on the floor, then that bacteria can fall right up that spout in the bag, up the tubing, and into the patient. So that's an infection risk. Do not reuse catheters in the hospital. It's a one-time thing. When it's done, we throw them away. Do not lift the bag above the patient's waist. So what's the problem with that? And all that urine's gonna drain, that's been sitting in the bag at room temperature for who knows how long. All that would go right back down the tube and into the patient's bladder, and bam, they have a urinary tract infection. Do not let the tubing get kinked. If that happens, what would happen? The urine isn't gonna be able to get out of the bladder, right? Because it's gonna come down that tube, and the tube has a kink in it. It can't go anywhere, so it just starts backing back up into the patient. Some things to do, we do need to empty the bag when it becomes at least half full. Do provide catheter care per facility protocol. Do secure the tubing to the body. So you'll have a leg band that secures that tubing to the patient, or some device so that the tube is not just hanging freely and pulling on the patient's perineum. Do assess the color, the odor, and the characteristics of the urine, and document that finding. So if you have a patient with a Foley catheter or an indwelling catheter, that's part of your assessment. The color, clarity, the amount, the odor of the urine that you notice in the bag. And do remember that their urine output should be at least 30 milliliters an hour. If it's not, then we need to notify the physician or the provider. So it doesn't literally mean that every single hour they need to put out 30 milliliters, but it means in a typical 4-hour time, how much urine should they put out in 4 hours? 4 times 30 is 120, so we should be looking. Are they putting out every couple of hours? Are they putting out a measurable amount of urine? Okay, good. Okay. So, you're gonna learn more about Foley catheters in lab, so I'm not gonna go through this. This is what you're gonna talk about in the lab. There's some patient teaching for urinary elimination problems. So page 323 in your book, there's a whole section on patient teaching. RNs, you need to know about this. LPNs, you also need to know about this, because this is teaching that you're gonna be reinforcing. So this applies to you too. And then on pages 320 to 324, there's a summary of urinary elimination issues. So I'm giving you some hints here. I'm doing all I can to give you hints, okay? Of things you need to read. The smart student takes the hint. All right, now, last thing. This goes from the section that I told you about earlier, pages 288 to 290, about reading about the newborns and the school-age child and the pregnant women and the elderly. This information comes from that section. You need to do some research of your own and answer these questions. It's literally in the reading sentence per sentence. And the same here for older adults, is all in that section. So these would be some good, if you study in a group with other people for your test, these are good study questions to go over with the people in your group. Discuss them. Okay. Woo! We need a break.